All right, hello everyone. I'm Franklin King, and I'm going to give you a little bit of a clinically oriented talk on psychedelics. So I'm going to tell you a little bit about how they work on the body and on the brain, and then I'm going to go through some of the clinical studies that have been done that are one of the many reasons that there is so much renewed interest in this field. I know you guys have my introduction already, but I'm a clinically practicing psychiatrist at Mass General, and I am also the Director of Training and Education in our brand new Center for Neuroscience of Psychedelics. So this is an area that I've been interested in for a very long time and really happy to be here talking with you about it. So just some definitions before we get going in terms of what we mean when we're talking about psychedelics. So the term itself directly means mind manifesting. Most of you probably know that already. And I like to think of psychedelics as being substances that elicit these three things. So the first, and I put these in this order on purpose, is number one, really producing a significant change in consciousness. Okay, and this is something that usually is experienced as being profound and transformative, often with spiritual importance or mystical importance to the person undergoing the psychedelic experience, as well as something that's very personally meaningful. And alongside this is this idea of ego dissolution, right? So this is a little bit difficult to sort of put into language in terms of what we mean by this. But generally speaking, ego dissolution refers to this experience of the fact that there's a decrease in the boundary between the self and the entire rest of the world. And so that experience is kind of where this whole idea of transpersonal experiences comes from. The dissolving of this boundary between the self and the rest of the world, and people can have all sorts of different experiences. They can experience themselves as being increasingly connected to the rest of the world, or identified as someone else or a different gender or an inanimate object or an animal. And so really these are sort of these two fundamental attributes of psychedelics that I think most people who experience healing from psychedelics in these clinical studies would report as being kind of the primary vehicles through which this happens. Now I say that because the third thing that does happen under psychedelics is this heightening of sensory experiences. So synesthesia, the combination of two senses being experienced is one, heightening of visual imagery, what might be called more pseudo hallucinations, because people maintain awareness that what they're seeing, if there's a distortion of the visual field, they're aware that this is not actually real. So it's not a true psychotic hallucination. But really, I think when you see lay depictions of people under psychedelics, you often see people sort of cartoonishly running after butterflies that aren't there, or sort of being really affected by the things that they're seeing, believing that they're real. And that really is sort of a misrepresentation of what happens under the experience of psychedelics. And I think that the visual aspects tend to not necessarily be the fundamental things that people take away from their psychedelic experiences in terms of how they are ending up catalyzing personal change. So just specific substances that we're talking about, there's a lot of different elements that people might say have psychedelic properties. Usually we're talking about the tryptamines, which are LSD, psilocybin, which is in magic mushrooms, or DMT, which is in ayahuasca, along with some of the phenethylamines like mescaline and MDMA. I'm not going to talk about ibogaine or ketamine, both of which have been described also as psychedelic. Ibogaine probably closer to the aforementioned than ketamine. So really focusing on these 5 molecules for the purposes of this talk, okay? Now, in terms of safety and physiologic effects, it turns out that psychedelics actually tend to be very well physically tolerated, which is interesting, right? When you're going to go study a drug, usually the sort of main concerns are what are the effects on the body. And it turns out that psychedelics are very well physically tolerated. You get about a little less than half of people report one of the following, either headache, nausea, or fatigue, which some of you may refer to or know as body load in the community. And then sympathetic nervous system changes, that's your fight or flight response. There can be a slight increase in things like blood pressure and heart rate. These are really mild. This is not something that significantly causes hypertension, so you'll see a slight increase, maybe 10 beats per minute of heart rate, 10 millimeters of mercury blood pressure, slight increase in temperature, obviously dilated pupils. And if you check reflexes of someone under the influence of psychedelics, they're likely to be increased. But really, they are well tolerated even in medically ill subjects. So there's been substantial amount of work at this point in patients with terminal cancer. There's been some preliminary work in healthy geriatric patients with LSD that was published about a year ago. And there's really not a lot of toxicity data. We don't have any lethal doses for the commonly used psychedelics like LSD or psilocybin. It's likely that it's in the grams or kilograms, which is a lot if you consider the fact that LSD is dosed in micrograms and psilocybin is dosed in milligrams. Also, no evidence for mutagenic effects or neurotoxicity. This is the stuff of some of the federal American anti-drug campaigns from the early 1970s, where they were showing mutated chromosomes and the like from people who were taking LSD. That's not actually based on evidence. But psychological safety, there's this idea, I think, more in the lay public of the bad trip. And what is that actually referring to? It's referring to a variety of negative psychological experiences, things like anxiety, fear, panic, dysphoria, paranoia. This can occur across a variety of modalities that I've listed here. But I think it's important to remember that when being used therapeutically, there really is no such thing as the bad trip. Okay, there's nothing good or bad. It's more that the therapy experience really is designed preparing the patient to sort of go into this, to be open, to be curious, and to really just sort of let whatever comes up, come up and explore it. Okay, so I think this is a significant contrast with a regular clinical study where if there's any sort of quote unquote adverse effect, you're going to jump in and sort of give a rescue dose of some kind of medication for a patient. And this really isn't done. You have to, in the protocols, have some sort of rescue medication like a benzo, like Ativan, or an antipsychotic, but really these are not used. And the primary quote unquote intervention is really to sort of prepare the patient to go into this experience, whether it's experienced as negative or positive, and sort of explore. The therapist is there to sort of help the patient hold the space if something difficult comes up. But by and large, people, regardless of what they actually are going through in the psychedelic session, whether it's experienced at that time as positive or negative, really tend to report both experiences, positive and negative, as being those which help them catalyze whatever it is that they might have wanted to get out of the experience. Okay. In terms of screening people, so for most clinical studies, people who have a history of psychosis at this point, or bipolar disorder, are usually screened out. So this really is based on a number of anecdotal reports and also one clinical report from the 1960s. There was one subject who had a twin brother with schizophrenia who experienced a period of prolonged psychosis after being given LSD in a clinical study. Okay, so it's worth mentioning that the field of research in psychedelics, despite them being used obviously across the world for thousands of years, but really the field of research is still quite young. And so there's a lot that we don't know. And so there is this potential idea that those who have either a family history of a psychotic disorder or a personal history of psychosis are potentially at increased risk and therefore would be excluded from most of the clinical studies that are going on. Now, again, thinking about what we're talking about here, we're not just talking about psychedelics, we're talking about them being used as part of a therapy structure, psychedelic-assisted psychotherapy. So this is very different than unsupervised use, recreational use. So, everybody here, I'm sure, is familiar with, media reports that are often sensationalized, but they are real. And occasionally, people that are not using them in sort of more of a structured setting or with an intention, there have been catastrophic behaviors, things like suicide or people accidentally hurting themselves by running into traffic, jumping out of windows and things like that, that end up, of course, being highly publicized, but they do occur. So really, preparation, the setting itself, psychological support are really important for psychedelics. Now, what about the psychological effects? So the psychological effects, one of the main things that I think is behind the hype with psychedelics is that the effects seem to be so long lasting, right? So, I mean, this is, if you give somebody a usual medication, for example, something that I might prescribe as a psychiatrist, like Ativan or something like that, the effect of the medication is only going to last as long as the medication is in their system. But this is not the case with psychedelics. The effects actually are quite long lasting. And people time and again report, an experience of increased well-being, enhanced appreciation, increased openness. And this really, like I was saying before, goes even for those, and perhaps especially for those who experienced a significant dysphoric reaction or some psychological turbulence during the actual psychedelic session, right? So people still come out of these experiences as having experienced something that really was enriching or meaningful for them. And I think, there's many studies that illustrate this nicely, but this one is a Hopkins study, which took a non-clinical sample of people who had a daily spiritual practice, right? So these are people who spent a significant part of their day doing something spiritually oriented, praying or meditating. Okay, and you found that 14 months after being given a single session of psilocybin, again, within the therapeutic structure, still reported that 2/3 of them reported that this was among the top 5 most spiritually significant events in their lives. And so something really important, personally important, seems to be happening under the influence of psychedelics. Now, in terms of psychology research, one thing that's interesting is that multiple studies have reported that after one or a few sessions of a psychedelic, that people are scoring in lower numbers on this personality factor known as neuroticism. This is not exactly the same as what people say when they use the word neurotic in non-psychological terminology. This trait of neuroticism is one of many personality traits that by the age of 30, human beings are thought to have sort of stabilized, right? So once you reach 30, if you take a personality inventory, you're going to score essentially the same on that when you're 30 or when you're 50. This obviously has been a little bit contested, but by and large, this is sort of the field's way of looking at people, that once we reach adulthood, there's certain personality traits that don't change. This goes for whether you're depressed or not depressed, whether you're anxious or not anxious. And this trait of neuroticism is linked to increased susceptibility to the negative effects of stress, to developing negative affect, depression, anxiety, somatization. So it's a risk factor for the development, not just of many mental illnesses, but it also is a risk factor just for generally handling stress poorly. And it's associated with a number of also psychosomatic and functional disorders that we see more in the medical clinic than in the psychiatry clinic. And interestingly, psychedelics over the long term, so months or in the MAP study, even years out, are showing decreases in this, what is supposed to be a stable personality trait. There's a couple of other personality traits, this idea of openness to experience, as well as the balance between introversion and extroversion. And some evidence has also shown that these things change over the long term as well. And again, these are following 1 to 3 psychedelic interventions, depending on the study. Now, normally when I'm talking about psychedelics, I go a lot more into mechanisms, but I'll just touch briefly on this idea of the default mode network, which has only been known about for about 20 years, but the default mode network is a network in the brain. So your brain has multiple different networks or parts that are talking to each other. That's involved in an experience of sense of self. Embodiment, it turns on when you're asking people to retrieve autobiographical memory. It turns on when people are daydreaming. It turns on if you put people in a functional MRI scanner, lie them on their back, say, close your eyes and think about nothing. This is what turns on. And the default mode network turns out to be pathologically aberrant in people, particularly who ruminate within depression. But it's also linked to a variety of other mental disorders, including addictions, some element of aberrant default mode network activity, all right? So what's interesting is that decreased default mode network activity has been shown across many different psychedelics, right? So it's been shown with psilocybin, it's been shown with LSD, it's been shown with ayahuasca. One study found that the magnitude of the deactivation actually correlated with the subjective effects. So sort of how intense the psychedelic experience was directly correlated with how much you turned off this network. So this is really interesting that this network that's kind of involved in our sense of self is precisely what actually seems to be impacted by psychedelics, and probably is implicated in exactly how they work when used for the purposes of healing. Okay, so when we're actually using psychedelics, how are we actually using them in the clinic, or at least in clinical research at this point? So originally back in the 1950s and 60s, there was this notion of psycholytic therapy, right? The field at that point was psychoanalytically oriented. Everything was based on ego defenses. And it was thought that psychedelics in sort of moderate doses, not microdosing, but not full psychedelic doses, could be beneficial in essentially reducing the patient's ego defenses to make therapy more effective. And so they would give moderate doses of LSD to patients and then basically do psychoanalysis with them. But gradually there sort of arose this competing and eventually dominant model of psychedelic therapy or psychedelic-assisted psychotherapy. This was a therapy model that really wanted to create a transcendent experience. So using much higher doses of psychedelics, back then usually LSD. And at that point, the therapist's role, it wasn't the therapist sitting there sort of doing psychodynamic psychotherapy or psychoanalysis. The therapist's role became more of a supportive, holding space position for the patient, right? And really the therapy itself took on more of a focus on preparation. So there was extensive preparation, especially back in the 1960s. People would often meet for a month or more with their therapist and go very deeply into sort of psychological background, as well as sort of preparing the patient, also utilizing suggestibility for the upcoming psychedelic session. And then there were integration therapy sessions afterward that really are designed to sort of help process what occurred, what material came up, help the patient think about what happened, what came to light, and hopefully be able to integrate those insights into their life for a more robust effect. All right, it's worth mentioning that back in the 1960s, not just limited to the fields of psychedelic research or even psychiatry, there was a lot of unethical practices being used. So there were some studies that really didn't use any therapy structures at all. One of the most notorious ones basically gave people 8 tabs of LSD equivalent, tied them to the bed because they were worried. They actually were scared they were going to give them seizures. They were giving them so much, so they gave them an anti-epileptic injection before they gave them, and there was no therapy. So really this was nothing short of unethical. And unsurprisingly, studies like this did not get the promising results that the studies using more of a psychedelic-assisted psychotherapy model used. Now, interestingly, this psychedelic therapy model really has kind of made its way back into research, and all of the studies that we might hear about today are based around this model, right? So this was largely from the work of Stan Grof, who also obviously created holotropic breath work. And they utilized this sort of therapist being present, a lot of preparation, a lot of integration, and that's really more where the talking piece happens. Also focusing on set and setting, set being mindset. The setting has to be humanized. You cannot do this in a sterile hospital environment. So you have to humanize the way the room looks. You have a quiet room, calming decor. Music is usually played, and usually instrumental music or music with non-English words if you're doing it in an English-speaking environment. And then people are also given eye shades, right? And so this is obviously not an academic medical center. This is one of the MAPS study sites, I think in South Carolina. But really all of the studies that are being published today, some attention has to be paid to the setting. And so if they're conducted at a university, in a hospital room, before the therapy session starts, curtains are brought in, there's wall hangings, a carpet is put down, there's a bedspread on the bed, real pillows, not hospital ones. So all of this stuff actually matters for the therapy portion. I'm going to wrap up just talking about some of the clinical studies on psychedelics. Right, this one came out of England. It was published in 2018. This was an open label study from Robin Carhart-Harris's lab, where they used psilocybin-assisted psychotherapy for patients who had treatment-resistant depression. Right, so they already had to have failed a certain number of treatments for depression prior to entering in this study. Over the course of a week, they were given 2 different doses of psilocybin, one initially a sort of moderate dose and then a high dose, utilizing that psychedelic-assisted psychotherapy model. And then they were followed for 5 months after the study. And what they found is that depression scores significantly and rapidly decreased. All right, so I'm not going to go through this whole thing, but I just want you to look at the top left here. You're looking at a number 34.5, which is the Beck Depression Inventory. And that basically is just a quantifier of depression. So 34.5, that's bad. That means significant depression. And then 1 week later, this really significant drop by more than 50% of scores. This is something that we almost never see really from any psychiatric treatment that we have. But even more interesting, there's a little bit of uptick in the score, but 3 and 6 months out, you see this persistent reduction in scores, even though there's really no treatment, or at least no intervention that continues to be done to perpetuate these gains. So really impressive results. Something similar published also in 2018 from a group in Brazil. This was actually a randomized controlled trial done on an inpatient psychiatric unit. And you kind of see similar things. You see what you're looking at in the red is the ayahuasca group, and the placebo group is shown in blue. Not surprisingly, on day 1 and day 2, both groups actually have a substantial reduction in depression symptoms. Now, I say not surprisingly because the groups that got placebo still got all of that therapy, right? So they got all the preparation sessions. They were in a room for 8 hours with 2 therapists present. So they both had some response. So there is a placebo response. But then you see that by day 7, the placebo group scores start creeping back up again. And likely, if we had sort of more follow-up from this study, I think you could hypothesize that you would see a persistent reduction in the ayahuasca group, whereas the placebo groups would probably continue to creep back up to where they were before entering into the study. All right, this is a newer study. This came out just last November. This was from the Johns Hopkins group. Similar results. Okay, they compared people who got psilocybin right off the bat versus people who were put on a wait list to get into the study. Okay, so they gave 2 psilocybin sessions, and they found that overall, substantial reductions in depression scores in both groups, right? So what you're seeing in the top graph there is that the people who were put on the wait list did not have any change in their depression scores. But then ultimately, after week 8, they too were put into the same protocol that those folks represented by the yellow dots were with the immediate treatment, right? But overall, both groups in sequential fashion ended up having significant reductions in their depression scores. Now, there's this interesting aspect of depression anxiety that occurs in people who are facing end of life, particularly from terminal cancer and other life-threatening diseases. And I'm not going to go through this study, so I don't mean to terrify you with this very busy slide. I'm just going to focus on these 2 studies down here. But right at sort of the conclusion of the initial wave of psychedelic research back in the late 60s, early 70s, right as the curtain was starting to come down from the federal government on funding this stuff, one of the most promising avenues of new research was helping people who were facing a lot of depression and anxiety and difficulty in general, coping with the effects and with the diagnosis of terminal cancer. And so Charlie Grob at UCLA brought this back in the mid-2000s, published this small paper up top. And then this was built upon by these 2 really nicely designed studies that were both published in 2016. And the short on these 2 studies from Hopkins and NYU is that they recruited people who were having either depression or anxiety that was associated with life-threatening cancer. And they got a single session of psilocybin-assisted psychotherapy. And at 6 months, 80% of them, 80% in one group, 60 to 80% in the other group, continued to have significant reductions in their depression or their anxiety. And the qualitative reports from these studies are really interesting. But again, you see this sort of brief intervention leading to sustained change. All right, so finishing up with addictions, which is how psychedelics initially were really first studied. Back in the 1950s, it became the standard of care briefly in Saskatchewan, Canada, under this guy by the name of Abram Hoffer. And simultaneously, Bill Wilson, and Bill Wilson is the guy who founded Alcoholics Anonymous, or AA, ended up not having any relation to AA, but he was ended up undergoing LSD-assisted psychotherapy in 1956. He had this LSD experience. And he ended up feeling that this must have some sort of application in recovery, went up to Canada, met with Abram Hoffer, and ultimately became a huge proponent of using LSD as something that could catalyze spiritual breakthroughs in patients that were having difficulty sort of getting into the treatment model of Alcoholics Anonymous. And he actually wanted to put it into the protocol for Alcoholics Anonymous. The board of AA wouldn't have it, became a little bit controversial at the time. But I think his perspective on this is interesting. He didn't think that LSD by itself was this sort of magical miracle drug, but he did feel that it could kind of help catalyze or create the beginning of a process by which LSD could create, what he said, an incentive to move towards recovery. So there were a lot of papers published on this in the 1950s and 60s, alcohol use specifically. And by the research standards of today, a lot of these trials wouldn't pass muster, but a pair of folks did go back in 2012, kind of take the better designed trials, amalgamate the results to do what's called a meta-analysis, just to see, were these trials successful? Did LSD therapy actually reduce alcohol use? And it turns out, unsurprisingly, that it did. This has been built upon by the team at NYU, who published a very small study a few years ago using psilocybin built into kind of a motivational enhancement therapy structure for reducing drinking. All right, I won't go through the details, but this is a small study and it was open, so you have to take the results a little bit with a grain of salt, but really kind of similar things with depression, right? You see this rapid reduction in drinking days and heavy drinking days that was sustained for several weeks out. Right, they're actually continuing. There's a much larger study that's ongoing. It's been delayed, I think, as has everything by COVID, but really looking forward to seeing the results of their, what I think is a phase 2 study coming out hopefully soon. Over on the other side of the Atlantic, Ben Sessa has an ongoing study using MDMA-assisted psychotherapy for patients with alcohol use disorder. So there's a preliminary paper with some really interesting results. Again, I think the qualitative reports, what patients actually are saying, are as, if not more compelling than the actual data points. But definitely encourage people who are interested to read some of this stuff. Wrapping up with nicotine, right? One of the worst addictions and probably responsible for more disease than almost any other substance. We had a paper coming out of Johns Hopkins a few years ago, and then a series of follow-up papers. Again, this is an open label study, but they used 2 psilocybin sessions to facilitate smoking cessation. They took 15 people, found that 80% of them were completely abstinent from smoking at 6 months. 67% were still abstinent at a year, and 60% were abstinent at 30 months. You might look at this and say, this isn't 100%, it's not 90%. But if you've ever known somebody, or for those of you that work in the field, trying to get people to quit, this is one of the most powerful addictions, and getting results like this, even getting more than 50% of people to quit smoking with such a brief intervention, is really nothing short of almost miraculous. So hopefully more data will be coming out on that. Again, there's some really nice qualitative reports from this study. I don't think, in the interest of time, I'm going to read this slide and just move on to future direction. So I think right now we're it feels like we're almost heading into the kind of exponential part of the curve. We had Imperial College was the world's first psychedelic center. Then we had Johns Hopkins. We at MGH just launched our center a couple of weeks ago. Meanwhile, there's all sorts of ancillary stuff going on. Berkeley launching a new center for psychedelic science and a therapist training protocol. You have the California Institute of Integral Studies opening another campus for training in Boston. University of Madison, I just saw, this was just 2 days ago, or it was actually yesterday. University of Madison just announced that they're going to be offering a master's program in the therapeutic use of psychoactive drugs. So really, a lot of stuff happening in the field, really exciting time. And yeah, I think I'm right at time. So I will see you all for the questions, but thank you so much.